Most patients have common questions like, what do I have? Is it serious? How long is it going to take to go away? Do I need surgery? What does it cost? Does my insurance pay for it? We're going to cover none of that during today's presentation. Look at these topics as areas I think you should master, that if you do so, they'll be good portals for future conversations. And if you do master these areas, you're inadvertently going to answer your own questions as to like what, whether something's serious or not. And let's go to the next slide. I'll let you read through these. Turn on my laser. Yeah, so TMJ specialist, it's created out of thin air. There's no specialty called TMJ. And remember, the temporomandibular disorders are systemic conditions. It's not quite so simplistic. Oh, I'm going to do a procedure and I'm going to fix it, as one of my next slides will show you. So this is a sagittal section of a temporomandibular joint. This is an actual cadaver, and I'll give you a tour around. This is the marrow space. This is part of the mandible. This is a pretty normal joint. It's healthy. A little bit flattened over here, but this is the cortical bone. You can trace it and follow it. There's no perforations. Same goes over here. When you move your jaw side to side, this whole complex here slides forward and back. So moving your chin left and right, you get movement through here. And that movement is what provides nourishment to this little thing called a disc. That if you look, it looks nothing like a disc. It looks like a bow tie. This is cartilage. No nerve endings, no blood supply. The only way to get nutrients in, waste products out, is through the synovial fluid. So movement is good. You want to move your jaw side to side. And you don't want to clench your teeth. Clenching your teeth is like cardiac arrest. It compresses acid. No nutrients can get in. No waste products can get out. And superior joint space, synovial fluid is in there with its lubricants and nutrients. Inferior joint space, distance between your ear hole and this is less than 1 inch. So if you want to feel your temporomandibular joint, put your finger right in front of your ear hole and bring it forward about 1 finger width and open and close, and you'll feel the lateral edge of that move against your finger. Next slide. This is my longest standing patient, and was not a good day for this poor fellow. This is called a Lefort 3 fracture, where essentially the face separates from the base from the skull. And there were some brain bleeds, 2 brain bleeds, frontal sinus fracture, nasal fractures, bilateral orbital fractures, maxilla separated. Uh, there was mandibular fractures through here, and the 2 condylar fractures that I outlined over here. But this healed up pretty good. No surgery, no incisions anywhere. I mean, we had to do an incision here to take care of that fracture there, and there was a bunch of incisions inside the mouth to repair the separated maxilla. But this healed up good. So no incisions. We haven't having to go open this joint up and put screws in there and all that. And if you look over here, there's like a little tiny piece of bone, but essentially there was no resorption or anything. This just reattached. Over here, he lost a little bit of that little pointy edge, but this healed up pretty good. It's not real pretty. There's no pain. The range of motion is not great, but we're not going to get greedy. We're going to leave that alone. This is our main medical journal. 10 action items that is standard of care from black and white. I can get you the full article if you want, but I've summarized it for you. So you can pause it and read through it. I want you to read through this. I mean, it doesn't take sophisticated medical language to digest 95% of all this stuff. So read through these, and I've condensed these points into one page, like one or two sentences for you as well. But for right now, I just want you to contrast the highlighted items with this what this patient wrote on this next slide. So take a chance to read through that. And I do read fully your organizers that you fill out, the 7, 8 page one here. And I look for possible areas of, shall we say, unrealistic expectations. So reading through this, I'm like, yeah, jaw lock, I can help that. Trouble swallowing, yeah, I don't know. Yeah, sleep, yep, I can definitely, direct you. I got some good sleep physicians I work with. Headaches, absolutely. I love to treat headaches. Bring in the ear, I got some good ENTs I work with. This, I find it inadvertently ends up in my lap, like people thinking that the temporomandibular disorders cause it is very, 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 very common that they occur at the same time. But I can't tell, usually I can't tell people, hey, you know, quote, fix or manage or get this better and your ear ringing will get better. Often it does, but it's not like a one-to-one relationship here. That's typically like a neurological ENT issue. And choking, like that's kind of a fuzzy one. So, but I can definitely help people with, your jaw not working right. Like there's another slide that I have over here that I'm going to suggest you guys don't use these sloppy, scary words. Your jaw isn't usually, it's not locked. Like my definition of locking, it's locked. You can't move it. Like you can't move it at all. None. It doesn't move. So usually that's more like catching or it's not working smoothly or effortlessly. And so anyway, so fixing the TMJ, look how this contrasts with this next slide. So this is my college freshman roommate who practices in Ormond Beach. He's a podiatrist, and he loves these kind of surgeries. I mean, this is fixed. You're fixing. This is a dislocated ankle on a person with severe diabetes. So you can, this is probably going to resolve. I mean, somebody with diabetes has some challenges with healing, so risk factors go up, but typically this will go well. You can fix that. And that's contrasted with how an orofacial pain specialist thinks. So the key word being pain, so an orofacial pain specialist is interested in pain science. So how the pain matrix works. And this is a gross simplification of how the pain system works. But when you have an external stimulus that causes pain, like let's say a pinprick or something like that, three nerves have to talk to each other. It's like a relay. So the stimulus is out in what we call in the periphery, and that gets shuttled up to the first level here, which is in the spinal cord. And when it comes to the face or the TMD conditions, that's the that's the brainstem. But the first shuttle is here. That's called a primary neuron. Secondary neuron goes to the thalamus. That's deep in the medial part of the brain. It's close to the pituitary. So everything gets shuttled through there, and then from there, you go into the cortex, where finally, you get perception and interpretation. This is where psychology comes in. Like let's say, for instance, that a hockey player like lost their two front teeth. They're like, that's a badge of honor. I mean, that's almost pleasant for them. Oh, cool! Look at that. I'm missing teeth. I'm bloody and it hurts a little bit, but I don't care. Versus somebody who's 37-year-old single person, that happens, and they're going to have some pretty negative associations and negative emotions on that. So don't dismiss the impact of psychology that has to do with it and the real negative, like some people are catastrophizers, we call them. They kind of just make it even worse by imagining all the worst things that can happen. And here's a part, almost done. This is getting kind of specific here, but this is the descending part of the pain matrix. In other words, this is an inhibitory impulse that originates here, and it goes down, and it sends inhibitory signals to this, what's called the first order neuron here to calm the trafficking here. So that shuts down pain. So this is what we think is part of what's happening with the fibromyalgia patients that have a dysfunctional pain regulation of they just have body-wide pain, is this thing doesn't work. This inhibitory part doesn't work. You know, when we or I and we, the orofacial pain specialist, see a patient, we're always thinking of that. Where all is the pain? Is, you know, how big of an impact is psychology for this patient? Do we have some kind of dysregulation with this? You know, where and then the medications that I use, at what level are they working? So it's not just, you know, simple, oh, is there inflammation? You know, if there's inflammation, is there inflammation? Some people get too simplistic. Well, inflammation where? So anyway, so we'll go off to the next slide. So this is the summary of the standard of care, the 10 points. And some of this I'm not going to have that much to add. Here, that one, nothing further to add there. There's no such thing as TMJ. There's a group of conditions. There's another slide I got coming up for that I'm going to suggest you guys. This is a sloppy term. I'm surprised it's still around, but it is. It's probably not going to change in my lifetime. And it's not me. You know, some patients get kind of defensive when I bring up psychology, but it's a fact. It's a biopsychosocial condition, and it's multifactorial, meaning that it's a series of different things going on, not just one thing. Like you may have, or a patient may have had a long dental procedure and they're here and their jaw hurts and they can't open as wide as they could. So can you say that the dental procedure caused it? Yeah, I guess it's usually that's usually like the straw that breaks the camel's back. So yeah, for sake of communication, we'll just say that the long dental procedure caused it. But it's actually multifactorial. If you go to the FCI website, on the TMJ page, there's all the common risk factors. I listed out 24, or not 20. I listed out 10 of them. So next one here. So we don't get cute, you know, this works, you know, you take a good history, you know, you got to look at all sorts of things, you know, like when did the pain start? Have you had it before? Blah, blah, blah. What other kind of medical conditions do they have? Then from that, you start getting a suspicion of, well, it could be this, or it's definitely not that. So that'll guide the exam. Then after you do your exam, then, you know, considering what you found during your exam and your history, you might really not be too sure what all it could be, or you might want to confirm things. So you order some testing, blood work or imaging, stuff like that. Then you're going to start narrowing down what's going on. That's called our differential diagnosis. You know, what's most likely, what could it be? You know, what all could it be here? And then based on that, then you go, okay, well, I got a diagnosis. So then you come up with a customized treatment plan. Uh, we don't overemphasize images aren't the whole end, you know, that there's more to it than just the imaging. You know, imaging is just part of testing. So sometimes you can get an image and it just like MRIs. I don't order a whole lot of MRIs. You know, 50% of an MRI, they're going to have some kind of abnormality on there. The radiologist is trained to find stuff wrong, but it has no impact on the diagnosis or the treatment plan, and it just gets people unnecessarily worried. This here is called evidence-based medicine, and I don't think I have anything further to add there. I don't have anything further to add there. I don't have anything further to add. Actually, I do. In our training programs, this is built in the DNA of an orofacial pain specialist. Don't do irreversible procedures unless you're dead sure that this is going to help. A lot of times you end up making, you know, going from bad to worse. So typically, especially at first, you don't do any kind of irreversible things. So that's kind of the same thing. And I don't have anything further to add there. So let's go to the next slide. So this one, I could say that a lot of people, I think, it's not you guys' fault. It's not the patient. That's what you're told. You have TMJ, but you got to be specific. That's just way too sloppy. I mean, to say, well, how do you treat TMJ? Well, I mean, the common perception is you treat it with muscle relaxants, Botox, and a night guard. Well, it depends. You got to, do you have an actual joint problem? And if so, is it a rheumatologic thing? Is it autoimmune? Is it traumatic? Is it inflammatory? Is it neoplastic? And then, you do the same thing. If it's not intra-articular, if it's somewhere in the fascia, the muscles, then you go to the same thing. Is it autoimmune? So anyway, you gotta be way more specific than just, oh, I got TMJ. And then you gotta factor all these other things before you come up with the treatment plan on that particular patient. So let's go to the next slide. So for orofacial pain specialists, getting to the diagnosis is pretty straightforward. There's something somebody told me or I heard is I mean, it sounds simplistic. You can't diagnose what you never heard of. Uh, there's 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 something else I've heard that says that you don't find woodpeckers swimming in ponds and you don't find ducks climbing up the side of trees. So if I mean, as an orofacial pain specialist, we got a really broad base of all, and we understand all the different conditions. And if we're kind of not sure, we know where to send it. Do I send this to ENT? Do I send this to my friends, the neurologist, the rheumatologist, blah, blah, blah. But it's a pretty straightforward algorithm. Like for instance, someone like a patient tells me, hey, I'm having migraines or my migraines are causing my TMJ. We humans, we like to make sense of the world and we use the word cause a lot of times too freely. But I'd ask two questions. I'd ask, so you have migraine. Well, do you have any nausea? No. Do you have any light or sound sensitivity? No. Well, you don't have migraine. But all the conditions is basically you go through an algorithm kind of like this. So let's go through the next slide. So I made this slide because this is an area of a common area of doctor-patient mismatch. Humans are hardwired to make sense of the world. We like to know what causes that stuff. A plane crashes, what caused it? Somebody got murdered, what's the motive? Uh, and the highlighted part, that's typically where a patient comes in, and the unhighlighted part is typically where we're at. I mean, it's nice to know what caused stuff down, but it's certainly not necessary. Like, I want to know how do we turn this down or how do we turn it off if I can? And, I showed you the slide of my old roommate fixing stuff. I like to, what's the that saying? Is that, under promise and over deliver? A lot of my patients, they say, well, nope. They come in for their follow-ups and pain's gone. Oh, it's gone. I haven't had any pain in weeks. I don't, in my head, that's a remission. I don't say, hey, I fixed this person's TMJ. In my head, man, she's doing really, really, really good. Hadn't had pain in a long time, but in my head, I didn't fix that. And typically, patients are going to think that, oh, well, there's a like a product like a night guard or something like a night guard is going to fix it. Nah, it's not that simple. And the way I use process here, and let me go over that. The way I'm using process, and these are different. Let's do this. Or how I use process here. So, in other words, it's like a process, like a continuum of how to make patients better, like whatever it takes. It might involve along the way coming up with some kind of product or medication, or it could be one of our splints, or it could be injections, some kind of surgery, uh, versus process here. what I'm meaning by what kind of process, like if they're having pain, but what's going on molecularly, intracellularly, what's going on? Is it a neoplastic process? Hopefully not. Is it an autoimmune process? Is it a simple inflammatory process? Not that they're simple, but it's important that you know the difference between that, how that's used and how that's used. So next slide. I'm not going to spend too much time on that. Just be careful, with the language that you're using, because a lot of times the way that you use language will inadvertently trigger emotions that you might not be consciously aware of, especially that one. That one's deadly when you say, I've tried everything. So let's go to the next slide. I'm going to suggest that you assemble a treatment team that's somewhere tipped over towards kind of this mindset. And there's three distinct people on the treatment team. There's the patient. The patient is in charge of hiring and firing procedure expert and advisors or an advisor and following the instructions fully of what the advisors and procedure experts are asking that particular patient to do. Now, a procedure expert can also be an advisor and vice versa. So these people can't be the patient can't be the procedure expert. Although I've had people drill on their own teeth some kind of way, and they become their own advisors. I'm going to suggest that you kind of tip towards this. There's another mode of thinking that I've heard people say, hey, when it comes to your health and when it comes to your finances, you better know exactly what's going on. And there's a lot of truth to that. Just understand that, I mean, there's no way that a patient is going to understand stuff as well as these people that have been doing it for a living and have had all this extra training and stuff. But kind of a good way to do it is trust but verify. You want to know, like, at least the principles for sure. You want to know what the principles is, but do you have to know every exact little detail? And it's not a good idea to, I call it tinkering with the plan. Like, for instance, I just had a patient. I mean, she means well. She came back for a follow-up, still 24/7 pain, unchanged. And for this particular patient, recommendations that I had for her was the switch one medication class that she has called the SSRI to an SNRI, so we can both handle all the antidepressant and anti-anxiety benefit of that medication class. But the SNRIs are really good for pain. And she has headaches, she's got neck pain. And so I asked her, "Well, did you do that?" No, didn't do that. But I'm taking Flexeril, right? And then the other recommendation was that for her to get with a physical therapist to work with her neck, especially. So did you do that? No, I didn't do that. But I'm doing these exercises that some of my classmates that are in osteopathic medicine or something like that had coached her on doing. And the worst thing that had happened is somebody impregnated her with this dysfunctional belief that she could palpate her lateral pterygoid. And remember, she's in 24/7 pain. And but you can't. You can't palpate, you can't massage your lateral pterygoid. It's anatomically impossible for you to do that. But she has some kind of positive belief that if she sticks her finger back in there, that's going to make her popping go away and that's gonna somehow or another help her. So that's something I'm having a challenge with now. So next slide. So these are the six possible areas that you can make an impact on most medical conditions, especially the chronic ones. And these are what I call the four pillars. Here we go. It's having a little malfunction here with my laser pointer. So anyway, so the four pillars, these are grossly discounted. So even though that a patient might be doing really, really, really good in that, like I'm to the belief that, hey, you can always do better. You can take it up a level. But even if you're doing good at this, you can do better. But this is where the main focus is on treating either diagnosed or not yet diagnosed medical conditions will indirectly help what a lot of the TMD patients are here for. And here we have TMJ surgeries, and I'm going to show you the two extremes here in the second to last slide. That's physical therapy and our splints here. I think that might be coming up pretty quick. Yep, here it is. So here's our splint. They're always done the same principles. This is not the occlusal part of it. So I'm not going to coach you guys on the proper way of designing occlusion, which is on the reverse side. But I do them the same way on every patient, build the same occlusion, and it's the same thickness and the same uh, inclines and all that stuff. So that's a splint, and this is what's next slide is what's not a splint. So splints, mouth guards, retainers, that the patients they get interchanged and used interchangeably, but they're all very different. So I don't make retainers, I don't make night guards, I don't make night guards. We make splints, which is what that last one was. Like for me, it's second nature. I look at these things all the time, so I can tell that's a pink lady, that's a cosmic crisp, that's a Fuji. I look at these things all the time. So I don't know what the heck that is. That's some kind of mouth guardy thing. I don't know what that is. That's a sectional appliance. These things are dangerous. That's a sectional appliance. See how the front isn't touched. So none of these are splints. So this is some kind of sectional appliance. You see, these sectional appliances they put you in danger for tooth movement and relapse. So let's go to the next slide. Oh, here we go. So second to last slide. So TMJ surgeries. So the slide on your left, that some people don't even consider that a surgery. That's called arthrocentesis, where these small needles are placed in the superior joint space, and with saline, you wash out the joint. So think of it as changing the oil on your car. So it's just getting all the old stuff on there, replacing it with saline, and you don't even need any sutures for this. And then your body will replace the saline that's in there with fresh synovial fluid. It gets all the debris and inflammatory products out. So this is a total joint replacement. So incision line is made at the crease of your ear. This is the extreme surgery over here. So incision line is made here. If you look close, you can see the prosthesis here. There's two parts of this prosthesis. There's a part that gets fixated on the base of the skull, where the condylar piece rotates. And then over here for access, we do an incision kind of on the base of the mandible. So this, I've never had a patient of mine go directly to this. Like I've had some patient, like this particular patient was a failed past implant. This is one of my patients in Shreveport that I did with Dr. Kim at LSU. So we were replacing an existing total joint that had failed. So next slide. So I put this up there because you can kind of read that this patient inadvertently had gotten all the principles from that standard of care. If you read this closely, you can kind of see in her language that she's saying that, hey, I'm not pain free yet, but pretty much I'm pretty happy. And believe it or not, this particular patient, the surgeon, I see several, like every few weeks, I'll see somebody from this person's practice for a second opinion. He had recommended two total joint replacements for this particular patient. That's the surgery I just showed you a little bit before. No physical therapy, no medication, just straight to surgery. And she's also saying, hey, look, I may not be pain free, but you can kind of see this is like maybe a minor nuisance, but she knows how to take care of it. Hey, if it flares up, I know how to take care of it. So hopefully this has helped, and that's all I got.